Hello and welcome to my presentation. My name is Nanambi, and today I am going to be going over second degree AV blocks. Today I'm going to be going over the definitions, different types, characteristics, causes, adverse effects, treatments for these, and then I'm going to loop back around and talk about the 2-1 AV block. I'll have a slide with references at the end as well. Here at the bottom, I have pictures of all three of the AV blocks that we're going to be talking about today, the Mobitz 1, Mobitz 2, and the 2-1 AV block. So first we'll go ahead and go over the definitions. So a second degree AV block is when there is a signal originating in the AV node that is weak, or a signal that encounters a partial block down the ventricle. So Mobitz 1 is, or the Wünschbach, which I definitely could be pronouncing wrong, so excuse me, is a type of AV block that typically only lasts a few days. It is characterized by a gradually elongating PR interval until there is a P wave that does not have a subsequent QRS. And then there will be another P wave that does. Mobitz 2 is a block that again originates in the AV node, but only some signals pass through to the ventricles. Typically, patients already have a bundle branch block with this rhythm and are dependent on the non-blocked bundle branch to send the impulses through to the ventricle. There are three types again: the Mobitz 1 second degree AV block, the Mobitz 2 second degree AV block, and the 2-1 AV block. So there are going to be some characteristics for both. Some of them are similar and some of them are different. The most notable way to distinguish one from the other is that the Mobitz 2, the PR interval on conducted beats will be consistent, while in Mobitz 1, the PR interval will be elongated until the QRS is dropped. So there are some good pictures here at the bottom, again, demonstrating this. So with both of these rates, we are going to always see that the ventricular rate is going to be lower than the atrial rate because we're dealing with blocks. For Mobitz 1, the regularity is typically irregular, P waves are normal, followed by the QRS, except for the block P. The PR interval, again, gradually elongates until the dropped QRS. We expect for a normal QRS in this particular one, and that was going to be less than 0.12. And so on this bottom strip here, we can see that there is the first conducted P wave and there's a QRS. The second one, the PR interval, we can see is a little bit longer. And then on the third beat, we see that we have a pretty long gap between where the P wave begins and where the QRS should have started. And then the heart sends out another beat, and then that QRS is made. For Mobitz 2 second degree AV block, the rate again is going to be between 60 and 100. Ventricular rate is going to be less than the atrial rate. This one can be regular, irregular, or regular but interrupted. All of the P waves are going to be normal, followed by a QRS, except for the blocked P. And then the PR interval is going to be consistent on conducted beats. Now on this one, the QRS can be normal, or can be more than a normal QRS duration. So if the block originates in the AV node, it will be less than 0.12. If it originates further down the line, it will be more than 0.12. This strip, again, is a very good example. On this first beat, we can see that we just completely missed. There is a P wave that is dropped and no subsequent QRS. And then we have another P wave and an immediate QRS after that. Then we have a normal sinus rhythm beat, and then we see where on the third beat there's another P wave, and then it's dropped. We send another P wave and then a QRS. It's important to note on this one that we can see that on the conducted beats, where there's a P wave, the P wave in the QRS, the PR interval is very consistent, very uniform. This is unlike the Mobitz 1, where we see it's gradually getting longer and longer. And then we see that we just have it dropped and then having to start another P wave for another QRS. Mobitz 1 can be caused by myocardial infarction, digitalis toxicity, which is basically when a patient can be taking medications for heart-related issues and then it becomes toxic to them, and then other medication side effects. Mobitz 2 second degree AV block can also be caused by myocardial infarction, conduction system lesions, again, medication side effects, as well as hypoxia. The adverse effects of Mobitz 1, usually patients are asymptomatic, and if a patient is asymptomatic, we don't want to give the patient any unnecessary treatment or medication, but it is important that we watch for a progression of a block. For Mobitz 2, if there are symptoms, there might be signs of decreased cardiac output, and then we also want to watch for the progression into a third degree AV block. We want to make sure that the block is not getting worse. The treatments. So the treatments for Mobitz 1 is going to be performing a transcutaneous pacing, and that is going to be this image here in the bottom right corner where you can see that there are the electrical pads being placed onto the patient, and this is just trying to help the patient stay in a normal rhythm or get them back into a normal rhythm. We can administer atropine if there is no transcutaneous pacing available and the patient is symptomatic. So again, we're not wanting to give the patient any unnecessary medications if it's not needed and they are not symptomatic. Most patients only need observation. For Mobitz 2, second degree AV block, we want to immediately get the patients to this transcutaneous, say that 3 times fast, pacing if the patient is symptomatic. And then again, we can begin medications such as atropine, epinephrine, or dopamine, as well as begin the patient on oxygen. Now we can loop back around and talk about the 2-1 AV block. So this is a type of AV block where there are 2 P waves for every 1 QRS, hence the 2-to-1. And this can be caused by Mobitz 1 or 2. So that's why I wanted to make sure we went over what Mobitz 1 and 2 were in the beginning, and then come back and talk about this 2-1 here. So 2-1 can also very much resemble one of the other 2 types of AV blocks. But it's important to note for this one that it's a pattern that we're looking for. We're looking for P, P, QRS, P, P, QRS. So the atrial rate on this rhythm is going to be 60 to 100, and the ventricular rate should be half, right? Hence the 2-to-1, so we want to see half. There are normal P waves, 2 per QRS, and the PR interval is going to be consistent on conducted beats, similarly to the Mobitz 2. The QRS interval is typically going to be less than the 0.12. Adverse effects of this could possibly be decreased cardiac output with low heart rate. And then to treat this, it's going to be similar to the other 2 because it's similar to the other 2. We can treat with a transcutaneous pacing if symptomatic again and a low cardiac output. And then the same medications, atropine, epinephrine, and dopamine. These are my references. And that is all. If there are any questions, please feel free to reach out to me. And thank you so much.